Already? Good afternoon and welcome to the Health Overview and Scrutiny panel. I'm Councillor Leonie Oliver and I'm the chair of the panel today. Just a bit of housekeeping before we get on to introductions. If the continuous fire alarm sounds, please evacuate the room and public gallery by the stairwells. Do not attempt to use the lifts. Please assembly at the turn-in circle at the end of King Henry Street past the University's Park building. If you don't know where that is, follow people that do. In order to comply with the Guildhall Trust's fire marshal regulations, anyone who has signed in at the Guildhall reception desk should sign out when leaving the building at the end of today's meeting. Can I draw your attention to the fact that this meeting will be live streamed and everyone speaking, please do so via the microphone, and there will be a camera on you. Members of the press and public are also permitted to record the meeting on the understanding that it neither disrupts the meeting nor records those stating explicitly that they do not wish to be recorded. Please can everyone use the microphone and remember to switch them off when they have finished. We'll go for introductions, please. Here we go, to my left.
Hello, I'm Gillian Harris, councillor from Havant Borough Council.
Councillor Susie Horton.
Good afternoon, Councillor Mark Jeffrey, St Thomas Ward in Portsmouth City Council.
Councillor Judith Smythe, St Jude Ward and Portsmouth City Council.
There we go. Thank you. Councillor Jonathan Brown from Gosport Borough Council.
Lisa Gallagher from Democratic Services.
Excellent. Members have read the reports. So presenters, please just highlight any developments that have occurred since publication. We've had apologies today from Councillor Matt Cordy and Councillor Leslie Minahan. Apologies. Can I ask if there's any declarations of interest? Perfect. And agenda item 3, minutes from the previous meeting. Has anyone had a look? They're all good?
Excuse me, Chair. I don't think I need to declare this, but just I don't know if it could just be checked. I'm now on the LGA Resources Board, but I don't think that would be anything to do with this. But
thanks for letting us know, though. No? Okay, that's good. We've got somebody creeping in. There we go. A creeper. Minutes. If everyone's fine, can I have a propose? I'm happy to propose and second. Yep, Mark. Perfect. Welcome late. Would you like to introduce yourself? Thank you. Don't forget to use your microphone. Thanks. So let's shoot on. Agenda item 4, Hampshire and Isle of Wight healthcare update. So, Wendy, please take to the floor. Of course, more the merrier. Sit on any seat, but just remember to use your mic.
Thank you so much, Leonie. Hello, everyone. I'm Wendy Rees. I'm the Managing Director for Hampshire and Isle of Wight Healthcare for the Portsmouth and South East Division, with my colleague
Simon Nightingale, Assistant Director for Social Care and also working with the Trust.
We've brought a proposal to you today. We came back in May for the first part of our proposal, which is about increasing home-based rehabilitation for people that have been in Queen Alexandra Hospital after an illness or injury, and also for people in the community that might need a little bit of support if they've been unwell. We've got incredible community services across this area, and we've already got a home-based rehab service called CRS that's run jointly by health and social care colleagues, and we wanted to increase the spaces available in that service by transferring some of the resources from our inpatient services currently at Summerlee House, where there's 40 beds. We've been testing this over the last few months We've reduced our beds at Summerley by 10, and we've replaced those in the home-based service by 10, and we've filled those spaces. That's been really successful. The waits currently at Queen Alexandra Hospital are generally for home-based services rather than inpatient community beds, so that's been really successful. So we would like to talk to you about taking the additional 10 beds from there to make Summerley a 20-bedded unit rather than a 40-bedded unit, allowing us to put 20 spaces in the home-based rehab pathway. Thank you.
Wendy, that's lovely. You've jumped straight to agenda item 5.
Oh, I'm sorry.
It's all right, you're keeping on.
Apologies.
But we can do 5, and then are you happy to come back to 4?
I will.
Perfect, okay. Questions? Anybody? Go for it. Susie.
Hi, thank you. It makes intuitive sense. I'm just wondering about the costs of somebody who is taking up a physical bed in a unit, and you said that equates to 20 places in the community. So do we deduce from that that's exactly the same cost of money, the cost to having someone in full-time residential to a place in the community for this particular rehabilitation?
So for the rehab pathway, the cost the cost of an inpatient rehab bed, which we currently run at Summerley, is generally twice the cost of supporting somebody at home. So all we're proposing is that we transfer the staff and some of the resources into the home base. So it's 20 beds less at Summerley equals 20 beds in the home based service. So it's a straight swap of capacity. So slightly less expensive for us to run, because obviously, hopefully, we all appreciate that money is a little tight. We do spend quite a lot on our inpatient services on temporary staffing, so the costs are quite high. So actually, this is much more economical for us to run a home-based service.
So, please correct me if I'm wrong. The number of people who are being helped is staying the same. The cost is being reduced. So is it seen as a cost saving? I suppose what I'm saying is why don't you have 20 less rehab beds in Summerley and 40 people being helped in the community? I'm just wondering why 2020 if it is so. It's better for the individuals. I get that bit. Being rehabilitating in your own home is I can see why that's good, but why not 40?
Yeah, I mean that's a really good question. At the moment, we would only really be able to afford to run the 20 on the basis that we do spend quite a lot on inpatient services, probably above what we actually have funded. But the investment in community is wider than that. So when we release money from a bedded establishment like that, the money goes wider than those pathways. So firstly, the patients recover quicker on a home-based pathway, so you do get more people through. So although it's the same number of spaces, we will get more people through the service than we would had they been in a bed. But equally, there's investment has occurred in other parts of the community that support people at home. For example, the hospital at home service, which is for people that are unwell. So the money has moved around a little bit. The more money we can move from inpatient sort of ward settings into the community, the better. So this year we've got more hospital home beds as well. So we've invested money in that. So the money's shared out in a slightly different way, if that makes sense.
Sort of.
Thank you. I just wanted you were talking about more home-based care. So do your patients come from just in the Portsmouth area, or will it be, because I noticed you talking about Petersfield and Alton losing care. So what's the extent of the home-based reach of your service?
So for Portsmouth City, it's 20 additional home-based beds, home-based spaces. So Simon can probably explain the service a little bit better because he's been running it longer than me. But yeah, Simon, you talk a little bit about that.
So from a Portsmouth point of view, we have CRS, which is a community rehab service, and that service provides a service up to PO6 from a council point of view. and a little bit further from a trust point of view. In South East Hants, and again, I don't want to mix up the two proposals, but from a South East Hants point of view, there's an equivalent service over the hill, which relates to then the similar proposal around the Petersfield beds. So the service overall comes under one division, but there's a city response, if you like, and then there's a South East Hants response. So this one is just about increasing our Portsmouth City offer. But overall, it comes under one division, and the next phase at some point in time will be how we make sure that offer, i.e. the service provision, is equal in terms of what it offers and how it does it across the whole division, so across the whole Portsmouth and South East Hants patch.
Thank you for this. I mean, I think in principle, nobody would disagree that people rehabilitate more quickly when they're living at home and they've got their books there and they've got television and so forth. But this absolutely will fail if it's not done with some other changes to practice, I think. And that means a tremendous leap in the use of communication tools like, for example, WhatsApp and things. Because if you're trying to support a relative or a friend in the community in the time that they're rehabilitating after a hospital episode, you just absolutely need to know when people are coming, when they're not coming, when they've been delayed. You know, people in the community support people who are rehabilitating by going to a hospital, which is a chore really and difficult and so forth. But if people are in their own home, people will often come from less far, and they need to know before setting out whether that is the time when the physiotherapist will be there doing something, or whether that's the time when somebody will be there addressing bandages, because it's a waste of their time to go and watch somebody giving health care. They need to know really in live time whether the person bandaging the legs is late, because they think, oh, I'll just pop in now then and deal with the library books I've got, or I'll just pop in now and share feedback on what I heard from Auntie Mabel yesterday. You need to have that absolutely live time support. It's nothing worse than having friends or relatives turning up on a visit where they can have a cup of tea or going to discuss politics or discuss the races or whatever it is. It's a waste of your time to go as a member of the family if somebody is in there giving treatment. And whilst sometimes you might want to do it in order to catch up with what the medical treatment is, as you would do around the hospital bed, it's not what you should be doing every day. And that'll just, if then somebody doesn't turn up, oh, they usually come at 12, they're not here, maybe just stuck in traffic, something perfectly legitimate. But in real life, even the very elderly would have somebody with WhatsApp saying, oh, no, it's okay, she's coming, she's on her way down, she's at Cosham at the moment, she'll be another 20 minutes. Let's spend the 20 minutes doing this. And if we don't get that, I don't think this will work. Because the alternative is the sort of conversation that goes, oh, well, they're always late. The NHS are terrible. They're always late. And no explanation. Yes, that's typical. And a part of the culture of disliking the NHS, which I pick up a lot in my casework around the police. People are always complaining. And I'm always trying to think of reasons why they shouldn't complain. And I think without using modern technology a bit more smartly, with a bit less, saying this is going to cost more money. It's not going to cost more money. Everybody has a lot of WhatsApps on their mobile phone, and people as they get older, who are of my generation particularly, will think, well, why on earth can't that be done? I think the alternative is that you will find there's quite a lot of time wasted in people dealing with people's complaints. You know, the visitor will still be there, if people are lucky enough to have a visitor, of course. And they'll be saying, well, you're late again. She's really upset she couldn't have her lunch, We just have to get real about on-the-day communications. And I'm very happy to offer help and advice from that. The other thing is just very simple things, like making sure that before the team talks to the person, they've actually got their hearing aids in. Spent a lot of time with my friend who had the desperate need for hearing aids, and the hearing aids weren't in. Medical professionals, even in Summerley, which I must say was the best place she stayed in, quite a long rehabilitation journey, where she managed to have good care. But even they hadn't looked at the bottom of the plastic bag with the clothes in from the previous rehabilitation unit to notice that there was a charger for a very modern pair of hearing aids. And I'll tell you what, my friend could shout and scream if she didn't have her hearing aids in, because she could not hear anything. That happened 3 times to us in that journey. I would say, she hasn't got her they'd say she's mentally ill, she's shouting at us. So no, she's not, she hasn't got her hearing aids in, where are they? So there's absolutely some basics that must be checked. And when people are in rehabilitation, they are much better off at home, in my humble, non-professional view. But these basic details have got to be absolutely sorted out. So the medical team coming into the place has got to know where the person normally charges up their hearing aids, for example. They've got to know where the bandages are kept. My friend used to keep hers behind the television, you know. They've got to be, you know, and that can all be achieved by a simple WhatsApp communication without any infringement of any. There should be some rules about that. You wouldn't want to swap information. You wouldn't want to share information that might get in the public domain, like where the keys were and that sort of thing. I don't want to go on, but I mean, I have a lot of very practical recent experience of people moving from rehab and into other forms of accommodation. And also, I mean, there's the whole business of working alongside people who are already providing care in the home for these people. Some of these people have already employed private carers, and we're dealing with different matters when people are poor, living on benefits and so forth, but quite a percentage of people who go into hospital and then require rehab have already got some arrangements. They've got a carer coming in that does the bathing and bathing and stuff, and new arrangements with the community health team. We've got to dovetail with those, not trample all over them, because it gives the NHS and indeed public services in general such a terrible reputation. And I won't go on, but you get the flavour of it. This is a risk in that we've got to make sure this is absolutely tip-top, and that it's giving us a revolution in communications between patients, whether or not the patients themselves can manage a WhatsApp app. Not many can't. My friend, neither of the people I've looked after could have managed it for themselves. But, you know, particularly in the situation I'm in now, because it's a next-door neighbour, not always. Sometimes I'm here. I'm doing other things. I'm working. But chances are, if there was a WhatsApp that came in about my neighbour next door, I could tell my husband, Peter's got a delivery, or he won't have the keypad for this. Can you let in somebody from the fire brigade? You know, that is a very simple action, and without those things being done by using modern communication, you're going to waste a lot of money. You're going to have a lot of frustration, and it won't be better than some of the. I hope that's helpful.
Any other questions or any other comeback? Mark?
Yeah, are you... Thank you. Are you able to sort of broadly or briefly summarise the feedback you've had from the City Council officers to the proposal and also the local MPs?
Yes, I'm happy to do that. So summaries provided to a point jointly. We have funding that goes into our Better Care Fund, and that goes towards supporting the unit, and it's provided the top floor of Harrisonic House, which is the council building. So we feel we have a vested interest in it, and a lot of people go to Summerley for social reasons, if you like, people who can't go straight back home because care package isn't available, or there's some other issues around the people's living environment. So not true rehab always. So from a social care point of view, we're really keen to make sure there is enough capacity within home-based rehab to see more people going home straight away for all the reasons that are in the paper, for the reasons we've discussed and just been acknowledged. So we've been part of the conversation, part of the proposal, part of the planning, to a degree. Yeah. Is there something specific you were alluding to?
Just generally, I was just trying to find out what the feedback might have been from City Council officers and the local MPs to the consultation, because obviously, you know, the consultation is great, but actually it's useful for us to know.
So from we have in Portsmouth something called the Better Care Fund, and it's a scheme that, if you like, talks about our joint investment across the ICB, local authority, and and partners. It's within our Better Care plan, which South and Wellbeing Board has seen and signed off and supports, to reduce our bedded capacity for rehab and invest more in Home First. Our current plan, our current iteration of the Better Care plan, talks about 10 beds, and the proposal we have here is to go a little bit further in terms of 20. So in terms of the principle, investing more in Home First care is something that we want to do as a local authority.
Thank you. And were the local MPs supportive as well?
Yeah, so we've been engaging with our MP colleagues. And so Stephen Morgan is supportive, so fully briefed. I've met with him. Obviously, representing the public, he wants to know that it works and that it's the right thing to do. A lot of the MPs have been concerned about the impact on Queen Alexandra Hospital, and obviously my colleagues here today, they're supportive of the proposal, and we've been testing it with them as well, just to make sure it doesn't cause any backlogs and further delays for people. And at the moment it hasn't. In fact, it's starting to improve that. But that's the type of work that we'll continue to do. And we're not stuck on one thing. So if we find actually next year that something else is required or we need to make a change, then we'll be responsive to the demands. But the patient demands at the moment tend to be more home-based support, because we know clinically that's much better for people. So that's great that we're moving towards that, but equally we would always be mindful that if we get demands in other parts of the health health pathways for people, that we'd want to respond to that too.
Sorry, I'm back on my beds thing. I just want to make sure that I understand this completely, because in the summary of the feedback it says that the number 293 beds across the trust has been... Sorry?
I was just telling the
Oh, sorry. Oh, sorry. Sorry. I thought you were correcting my number. I was going to say it's in the report. 293 beds across the trust division is maintained. And then when I look to the information on page 34, it's a very lovely diagram. My eyesight is not brilliant, but I think, yes.
That one.
Am I right in thinking that I'm just interested in the language here, because the language of the notion of beds being maintained seems to then cross between hospital beds and what you're describing as home beds.
Yeah.
So I just think it's really important that people... You also say on there that, according to whatever data it is, that the capacity for hospital-based rehabilitation exceeds demand. So that makes sense then. If there's loads and loads of empty physical beds in a hospital, and the demand in the community is not being met, it makes sense. But I think there's a little bit of... The language implies, for me, that when you talk about that the number of beds has been maintained, it implies that the number of... Because I was looking to where those beds were in the hospitals. So what we're basically saying is the number of people who can be helped can be maintained.
Yes.
But actually that doesn't... It's the language around beds. I think it's a little bit...
So we met with Wendy virtually last Friday, and actually that was the feedback, is that we needed to change it from the word bed. It needed to be changed from the word bed to like a complex care package. That is essentially what it is. It's a home-based complex care package as opposed to a physical bed. And that actually there is a big difference between your hospital beds and not just a bed. Service. Yes. So that was one of the take-backs that we had last Friday when we spoke, is that actually that language needs to be revised.
I absolutely agree. I think we were just trying to demonstrate the numbers, because it's really important that people see that we're not, because people will often say when you reduce beds that you're taking something away. So we wanted to describe it as not being taken away. so we are describing a home-based bed, but it is actually, it's a home-based space, isn't it?
I still think people are more. I think people are able to cope with the concept
Lovely.
that
Yeah.
if the demand is in the wrong is being met in the wrong place, I
Yeah.
think they can cope with the concept
Yeah.
that the number of beds has been reduced. But look what this has happened. Whereas I think that seems a little bit at best confusing,
Yeah.
at worst feeling a little bit smoke and mirrors.
Okay, no worries. Thank you so much.
Thank you.
I absolutely agree with that. The word bed implies that you need to have a hospital bed in your home. And there are many people living in places where they would not want a hospital bed if they haven't already got them, as some have got them, of course. And I think I can't quite see why you wouldn't call it hospital at home in the same way as the other service, because the full range of hospital expertise is available to these people rehabilitating from an operation of some sort. And in essence, that's the catchiest thing to say, hospital at home. And if you need to sort of talk about complex this, or it gets a bit, it's difficult to understand. But I think that does need to be changed. And it also makes the kind of smoke and mirrors bit of this seem a bit more suspect. And I absolutely agree with you. It's not clear. Amy, is there any reason why you shouldn't use hospital at home?
I think, Judith, that they've got obviously different phone numbers and different teams. So rather than confuse, and we've obviously confused you, so we appreciate that. It'll probably confuse the public too. But I think, the hospital at home model is a very different, it's an investment we've had nationally. It's a very different pot of money. It's a very different service. So we don't want to confuse really, because people will access hospital at home for different reasons. So, but we absolutely will work on, and what we'll do is we'll speak to the people that use the service as to what they feel it should be called. So I really appreciate you helping us with that.
I just think that the essence of this service is the same as hospital at home. And if you have two numbers for, bifurcate at some stage, that's fine. But it's a very good title, hospital at home. It says it all.
Good.
Doesn't
Well,
it?
that's good. Yeah.
So,
yeah.
And in fact, if it is like hospital at home, it is going to provide emergency access to people in the full hospital team, and that's what this service has got to do as well. So, yes, from the patient's point of view, it's doing just the same sort of things.
Yes.
It doesn't matter how you get there.
Yeah.
We don't want to multiply all these terms.
Okay. No, thank you.
I really. What did others think?
Yeah, I've got a slightly different question. So I'm not sure whether you're the best person to give me any advice on this, but you might know. So does this impact on any viability for Harry Sotnick House in the future from the Portsmouth City Council's perspective? Because obviously, I'm an elected member for Portsmouth City Council, and always local government's under pressure with budgets. So I'm just I am concerned whether there's any detrimental impact on the viability of Harry Sotnick House in the future because of this.
What it gives us is options and opportunity to have a look at how we use our estate differently. We've just released our market position statement, but we're also looking at how we commission things differently. So from a local authority point of view, is commissioning physical beds, as we still currently are, the right thing to do? So I think what comes next is to have a look at the options available. So for short-term services, do we still need to invest more? Can we use our resources differently? It's all up for looking at in the future. So initially, it doesn't impact our viability. It just gives us an opportunity to look at using spaces differently.
Any other questions? Perfect. Thank you. But stay put. And we'll go back to agenda item 4, please, Wendy.
Apologies, Leonie. So in relation to community nursing and the sort of out-of-hours community nursing provision, so as Simon explained, the division, as we formed New Hampshire and Isle of Wight Healthcare, the division boundaries have changed. So the division is across Portsmouth City and South East Hampshire. We found that across community nursing, across the division and wider into Hampshire that the provision is slightly different. So what we've proposed is and put in place is the alignment with the rest of Hampshire for community nursing. So I am a community nurse. I've been a community nurse for years. And many years ago, we ran a sort of a 24-hour service where we would work in the day and then be on call at night. For many reasons, that wasn't viable. Because the actual workforce, it's really hard to manage a 24-hour service with a workforce model that most of the work is during the day. You end up with an out-of-hours service that is difficult to flex and sometimes quite costly to run with temporary staffing. So we found in Portsmouth and South East Hampshire that we were still running the out-of-hours service, whereas a lot of the other areas of Hampshire had transferred them over to another provider many years ago. So currently in most of Hampshire, out-of-hours services for GP practices and community nursing are run by an organisation called PHL. So they actually work with our 111 service. So the GPs handed over that element of their service a number of years ago, probably about 10, and nursing followed that shortly after. The reason that works is because the out-of-hours nursing requirements often are urgent care type things. So people, for example, who may be, sadly at the end of their life have got medication or symptom control problems, or somebody who's got a catheter in that becomes blocked, and obviously that's quite an urgent need. So what we were finding is the out-of-hours provision is quite aligned to GP provision. It's sort of that multi-professional team you need. So we made a decision that we would bring all our nurses in Portsmouth and South East into the day service, which is 8 a.m. to 8 p.m. because we were finding it was really hard to run the service across 24 hours. So we brought those nurses back into that 12-hour provision, which is really key. Get all of the planned care work done, make sure we've got lots of people to do that. And then after 8 p.m, that service from the 1st of December will be with PHL alongside all the other areas of Hampshire. The calls out of hours are not huge. Generally for a division of this size, Portsmouth and South East, it might be about 8 calls a night. It's not many. That somebody would call 111, they'd get the advice they need, and then if they needed a home visit, there is a nurse available with a driver that will go out to their house, and also a GP available with a driver if they've got a slightly higher medical need. So we've made that change to transfer that service over, and now we just work from an 8 to 8 service in community nursing. That means we've got all our nurses in the daytime. We've got lots more sort of provision and resources to run the services, and we're hoping that patients, as you said, Judith, that they're not having their visits really late in onto the evening for things like bandaging, etc., and that we're able to do the work during the day.
Any questions? Judith?
Some of us who've been involved with the health service for a long time are very worried about the fact that Portsmouth has actually got a very good integrated service, and actually better than the surrounding areas. I used to be chair of the Health Authority and on your board. We were worried that the changes to an ICB would actually reduce our services in Portsmouth. Is this an example of that? Because we do more integrated work here still, and I'm very keen to make sure that that is preserved.
No, this doesn't impact on any of the integration, any of the Section 75s, any of the work we do with the local authority at all. This is about workforce resilience. We just were really struggling to manage a 24-hour service to a high standard. So patients would have visits that were really late in the evening, patients were waiting a long time, we had visits that were put off to the next day. So it was really about bringing our really precious community nursing workforce into a manageable working 12-hour shift, and therefore having the out-of-hours service, which is very different. People's needs in overnight are often very different. The advantages to patients very much are that they are then supported by that urgent resource, which is provided through 111. So there is a much better sort of multi-professional team. But absolutely, if anything, Judith, it's probably strengthened our ability to work with our partners in Portsmouth rather than put it at risk.
So it couldn't be seen as levelling down, which is in some transport is something that's happening by the ICB being so much
No,
bigger.
I don't believe it's levelling down. It was levelling to the rest of Hampshire, having tested a model for community nursing for some time that had worked really well. We haven't had, we haven't had any sort of negative feedback from patients in the rest of Hampshire about that service. They find it really easy to access. So we felt that actually we weren't providing the standard that we would have liked because we were so stretched.
Okay.
So I think it's probably going to improve the quality of service.
Is PHL a for-profit organisation?
PHL, I might have to ask one of my ICB colleagues, James.
It's a community interest company. Oh, good. Okay, gives me some comfort. I've done research into the use of different sectors, and I do find that the use of for-profit organisations to provide NHS services expensive and, according to my compass, wrong.
Yeah, I mean, we work with PHL really closely. I mean, in terms of workforce, really experienced nurses. Some of our nurses do choose to work in PHL, and some of our nurses who work the nights and evenings have chosen to take roles with PHL. But really good clinical director, really good. And they do run other services within Hampshire and Isle of Wight with us as well. So yeah, really good.
I mean, a lot of the public don't understand what a community interest company is, and I think it would be something that you should put in brackets at the beginning of a report like this to explain that it is part of the non-profit, not for-profit community. I mean, clearly you have to run a proper business and have surpluses and be viable, but that's not the same as making profits for greedy shareholders, in my view. So I think you need to be explaining that to people.
Yeah, of course.
No, thank you. This is. I was concerned about those two things, and thank you for answering the questions. Thank you, Chair.
Two quick things. One was going to be a question, but I think you answered it around resourcing, so that sounds a really positive thing. Do you have any, don't have to have at this moment, is there any data that could just demonstrate, for example, that there was spaces needed of nursing, and actually under this model more people are attracted to work in that seemed to be what you were saying, is that the resourcing was better in terms of staffing under this model, or would be?
We had stark vacancies, probably up to about 30%.
Okay.
In both the services. So we had obviously nurses that liked to work out of house, and I've done it myself when my children were small. But we had stark vacancies, so we were using a lot of temporary staffing.
Yeah, that's what
and what we found is we now today, for this change, when it starts on the 1st of December, every vacancy is filled in our core service with our own staff. So that's absolutely fabulous. Some staff, obviously, who have got children, we've helped into roles to support their sort of work-life balance. So some people have gone to the wards to work nights. Yeah. So we have obviously tried to redeploy people appropriately, but for the first time, in a year, we'll have every vacancy filled. I think that's really important. Obviously, I mean, if I'm to be totally honest, that we have reduced the numbers of staff available for the 24-hour staff. The number of staff for the 12-hour service is not the same number as for the 24-hour service, obviously, economically, because we have to give some money back to James and the ICB in order to pay PHL. So we've obviously moved some of our money that we get in. So we've not held all the money. We've got enough money to run the 12-hour service, and we have increased the number of people in that service. But if you looked at on paper, it's not all of the night staff moving into the day, because obviously we've had to release some of the money.
With the winter coming up, how do you feel that will impact the service?
I think it's really positive. I think from an urgent care perspective, in winter particularly, the speed people access the right clinician at night is important. So what would have been happening is they would have phoned us on a FlexTel number. The nurse may have been busy with a patient, so it would have gone to an answer phone. We would have phoned them back maybe an hour or two later. But if they ring 111, they're triaged at that point of the call. And if they need a doctor, they'll get a doctor, because our nurses could still go out, say, 2-3 hours later, think they need a doctor, and then have to call a doctor. So actually, I think from a service perspective for patients, they will be triaged a lot of advice and guidance as well from 111 over the phone while people are waiting. I think it's probably a better response for patients.
I just got a quick second one. It's in relation to communication, really. So in the past, I've had quite a lot to do with community nursing. And sometimes what happens is there's a lot of confusion about what you should, what you can do. And if you've got a bolshy daughter around to be assertive, I think there's a few of us probably in the room, and sons, then actually it's a bit different. But we know, don't we, that there's a lot of people who are quite lacking confidence and a bit more vulnerable. Is the communication, because a lot of them, I mean, they used to have like a physical folder, but a lot of them have key phone numbers to call. I think in a change like this, we need to pass on that change in culture to those people who might need it, so that someone's not sitting there at 8:10, as you say, for example, with a blocked catheter, thinking I now can't get access to my community nurse where I have been in the past, and actually ringing 111 is okay, because a lot of older people think that they come from the culture of 999, and actually you have to be seriously ill, and they might not realise how seriously ill they are. You get where I'm going. Communication.
No, absolutely. And it's always hard to reach every single person that might call, isn't it? But during December, we're going to both run the service. So we've got a bit of a handover. So there'll be a PHL team and us running it together. So we'll be able to communicate with the people during that month, you know, that it is changing. We obviously have done the communication now. Obviously, for the FlexTel number that we would use, we would put a message on there just to say, you know, please ring 111. But as much as we can, we will be engaging with people direct. Obviously, that a lot of the patients that call are known to us because obviously they know the service exists. So new patients tend to ring 111 anyway. Patients that know the service will be probably having visits and contacts with people during the day, so that we'll make sure they remind people about the out of hours change, etc. So hopefully it'll be okay. But I do appreciate that some people may, we may not have reached everybody, and it can cause some concern. We'll make sure we've covered as many bases as we can.
Any more from the floor? Brilliant. Thank you very much, guys. Agenda item 6, it's over to you, Andy.
Thank you, Chair. Good afternoon all. Andy Biddle, Director of Adult Social Care at Portsmouth City Council. So the report's in front of you. It's rather a long report, but it's shorter than it used to be, in my defence. What we've tried to do, we've had discussions here on a number of occasions, and what we've tried to do is limit it to the things that we think have an impact for our residents and that you'd want to know about and that we've spoken to you previously. And we've also tried to limit appendices, but I'll take it as read and I'll just pull out a few highlights if that's okay. So this is the second of the biannual reports that we're asked to submit to HOSP, and sets out the work of the service between May and October of this year. Section 4 sets out some of the national policy development around guidance and potential legislative changes, such as the forthcoming National Pay Agreement and things like the Liberty Protection Safeguards. The work of the KC Commission has commenced in April of this year, and we'll be making a submission as a council to the consultation around the National Pay Agreement for social care. We also highlight in the report the national picture for adult social care contained in the report from Skills for Care that's published in October, that talks about the workforce across the whole of the country for adult social care. Section 5 provides a reminder around our strategy and improvement plan, and everything that we do should flow from that. They're two documents that govern all the work that we do. We believe they're quite accessible to people when we've tested them with folk. And we also, in each of those documents, is a plan on a page setting out clearly what we try to achieve and why. And then section 6 is the main section of the report. It provides an update against our improvement plan activities. Some of the things to highlight from there would be our work on direct payments and encouraging micro-provision. Because if you can make use of a direct payment, you need something to buy with it, and that's why we're trying to work on micro-provision in Portsmouth. Sets out our work on improving the time that residents wait for an assessment support planning. I'm pleased to see that we are reducing our waiting times and our numbers of people on the waiting list for our residents on a regular basis. It sets out some of the challenges with ensuring timely assessment for our residents who are acutely mentally unwell, and the work with our NHS colleagues to try and address that for those people that need a Mental Health Act assessment. There's some detail there around our engagement and co-production with our residents, and we've put in just a few quotes to sort of illustrate the kind of feedback that we're receiving from people. We also, just as an aside, publish our complaints and feedback report every year to our cabinet members, so that's in the public domain, and there's more detail on that report, which I think was published in September of this year. There's a focus on our workforce as well. We're developing our workforce strategy. We're hoping to look at a first draft of that tomorrow with the senior team to try and ensure that we're planning for how we develop the right skills in our workforce in the future, and also acknowledge the fact that we, like many other places, have an ageing workforce. Apparently an ageing workforce is now people over 40, which makes me feel terribly old. We've also put some information in there about how we're commissioning support for our residents in the future. Whilst it's really important that we have the right support now, we need to be thinking 5, 10, 15 years ahead where things need building, such as extra care, residential care, where we think we're going to see changing demographics. So trying to get a longer term view as well as dealing with the support issues of residents today. And we've put in there some information around the procurement for our new record system and various other digital initiatives that we're trying to move forward with. I mean, some of those things that you've spoken about today have a clear link to that becoming digital for those people that can access services digitally without overlooking the fact that there'll be a lot of people that can't, and we need to maintain other more traditional forms of communication for those folk. Section 7 sets out the capital that we believe we need to progress 2 projects. One of those is the client record system, and the other one is the expansion of Sense Plus Portsmouth, which is a specialist resource that works with some of our residents and their families who have learning disabilities in Portsmouth. And then Section 8 talks about our details for governance in very simple terms, understanding how we monitor the quality of our services and the impact of the work of our services, but also how we ask other people to do that with us as well. So we are supported by our Regional Care and Health Improvement Advisor, who oversees our improvement plan on a bi-monthly basis. We submit data nationally to the Department of Health and Social Care. And we're also subject to regulation, as I think you know, by the Care Quality Commission. And so we've had an inspection from them as well. So that's sort of whilst we look at a lot of stuff ourselves, we also have other people looking at how we work and the quality of that work. In Section 9, we've set out some of our challenges and our risks. We act upon those where we can. Where it's a more sticky problem, we maintain a risk register that we review quite regularly. As most organisations do, so that we're aware of the strongest risks to our work and what we're doing about them and progress on trying to manage those. And then finally, the appendices to the report give you an example, our strategy on page, and an example of the recent visit from CQC, the assurance timetable, to sort of show the depth to which the Care Quality Commission went into to assess our services and how we provide them. Hopefully that's a helpful summary. Happy to take any questions.
Thank you very much. Judith, are you having a question, or is your mic just on?
My mic's still on, but I'd like to do a question when others have had a turn. Yeah.
Susie, go first.
I just wanted to make a comment that I was surprised that the ageing workforce should be 40 when I understand that people are going to be working to at least 90 before long.
This is a great report, really, really interesting, and most of it very, very clear. I'd just like to go back to the bit about co-production. You probably know that my past work on a national project about co-production. When you use it in here, I don't think it quite tells us enough. I mean, do you mean what co-production of what?
Probably use co-production as shorthand, so it could be anything from something like co-design, where we're doing something differently and we're asking people to contribute to that, to starting with a blank sheet of paper. So one of the examples might be we did some recruitment recently for our new deputy director, and we had a panel of people that we'd call experts by experience, those people that use services. So in recruitment, we would
Okay.
see that as co-production. We also, when we were talking about building a new extra care facility, we asked our design team and one of our architects to go out and talk to our residents of existing schemes about what's really important to them, how we can design a scheme that meets their needs, they having experienced it and lived there. It can be anything that we talk to our public about. We did some, I suppose what we once might have called mystery shopping at the beginning of this year, where we made some changes to the information that we put on our website, and we asked members of the public who'd agreed to be consulted about those kind of things. Was it easy to access? Did it tell you what you needed? Could you search on it? So we see it as very broad, anything that we involve our residents in to help make our services better, or to change them, to improve them, anything like that.
That's very clear. I'm glad you're doing that, but I don't think it's co-production. What you're talking about is client-led services and client-led process, and I'm really delighted to see how you're involving people who've got lived experience of these things and people who at different levels in recruitment and stuff. That's absolutely fantastic practice, but it's not co-production. The co-production is used, certainly was when I was working in this field, to describe co-production of outcomes. So it's about working together, usually at an individual or a family level, to co-produce the outcomes you want. So for children's services, it's working together to improve the number of children who are ready to go to school. For an older person, it's a objective, usually and often defined by them. Co-production of the aim of getting out once a week, or co-production of the aim of being pain-free and being able to do certain things you couldn't do before. Co-production of being a bit more independent in the, although that's another dangerous word to use. But I really think that the co-production I'm talking about is often about recognising that people who are not part of the social care system will have an equally important role. So it goes back a bit to what we're talking about with rehabilitation. So in other words, you know, if a little family team, or even a little WhatsApp that I was talking about before, gets together and says the aim is to get Muriel out once a week at the moment, and everybody's agreed on it, can you all report back on what we're doing to achieve that aim and the person, if they're able to use the technology, will be part of that. And co-production is really important when you're talking about delegated budgets, to lead professionals having budgets and doing micro-commissioning, which you talked about earlier. Because, in the work that we did, it was sometimes just buying a double buggy for a family could make sure that the children got to school, make sure all sorts of things fell into place, and it's a very small amount of money for the public purse to pay. And I unless the language has changed completely since I was in practice, probably about 5-6 years ago, I think that isn't co-production. It's perfectly good and it's wonderful, but it's client-led, client leadership and client involvement. It's not co-production. Co-production is about individuals and having the team around the person, which is actually the essence of what we were talking about with the hospital at home, rehabilitation at home service. It's about, it's as simple as, if your daughter comes down every Wednesday anyway, it's avoiding a public appointment with a social worker or with a carer or with somebody doing somebody's feet on that day, because it's going to put the daughter off from coming down and visiting. I just point that out because I think there is another dimension to this, which is related to the whole report, really. You do touch on it, is about teams around the person to achieve certain outcomes, which will automatically be individual. It's not a criticism, it's just partly as curiosity. Has the word changed meaning in 5 years? I don't think so.
If I could come back on that, I think we're talking about a range of things. So I think what you've just described to me would be working with an individual resident and or their family and or their network, their friends, to achieve certain outcomes that we'd probably do through care and support planning. And co-production on that individual level fits within the strength-based method that we're working to embed within adult social care.
It does.
So I certainly wouldn't disagree with that. And any work that we do with any of our residents, if possible, should have that focus on outcomes and should be co-produced. So we should be talking, for example, in a care and support plan about what somebody wants to achieve, and then thinking about the services that support them to achieve that if they're eligible for those services. I think probably the way that we describe co-production in the report was thinking at a wider level where you can have an influence on how a service is provided, or the example with the digital stuff, for example, if we had people come back to us and say, do you know what, that doesn't make any sense, we can't find a search term that works and actually your information isn't okay, then we'd change the way we provided it and we'd see that as influence. So I think it's a range.
I think the report shows that you are doing all the things. I'm impressed with the report, but that word in that place, I think, underestimates the importance of co-production with the team around the person. Thank you very much. It was a good explanation.
Don't forget your mic, Judith. I've just got one about the mental health services, but I'm wondering if the team later are going to be, but you stated in the report that you struggled to meet the requirements, and that the Chief Exec has written. Has there been any feedback since then? Thank you.
Yeah, so we've had discussions, informal discussions with the Chief Executive of the Trust. We have colleagues here present today, you've heard from them. And they're working toward a solution. The issue is a sticky one. It's been going on for a little while. And it means that we're pushing more, well, as you've seen from the report, we're pushing more and more assessments into the evenings and weekends. And when we're working with our residents who are in need of a mental health act assessment, they're in particularly acute distress and mainly are a risk to themselves. So we do need to resolve it, and that's why the Chief Executive owned it, as well as Adult Social Care owning it, which was helpful. We don't have a resolution at the moment. We are in active discussion and trying to figure out how we do that. I think the other bits that we talked about in relation to mental health, the availability of, for example, Section 136 beds, is an even more sticky problem because we are seeing a greater incidence of people who need that kind of help, and expanding those resources is really tough to do within the financial envelope. So I think that's going to be even more difficult to resolve. Hopefully the issue about getting what we call a Section 12 doctor can be resolved, I think, although it's taken us a little while to do so, but the availability of beds or a space where you can take someone to make an assessment is a difficult one.
Any more from the floor? Susie?
Andy won't be surprised to hear me draw attention to the carers bit of it. And by the way, it's a really good report, thank you. It's I've been sort of distanced myself from it. I was involved every day for a while, and it's really, really great progress, and some interesting stuff around the rehabilitation services as well, but I'll pick up with that later at some other point. On the carer strategy, I mean, all of this is like really lovely, but I just wonder to what extent now we're kind of working on a bigger footprint that there is engagement with national government around carers' rights. I was just reading something this morning, a case study where someone was literally out, sort of laying out the financial disadvantage of going to work, whether she worked or her husband worked. This was caring for a disabled child, but equally it could be a parent or whatever. And that sense of actually giving people some kind of sustainability rather than relying on the, let's be honest, filling in a billions and billions of pound gap that unpaid carers are doing. Now, we all know that, and we know that there's not billions of pounds out, but I just feel that there's an opportunity, particularly with the ICB structure, that there could be more, or is there more, engagement around, if not lobbying, then actually engaging at a parliamentary level about addressing this issue, which is, as we know, is going to get more and more significant.
I think the picture's, I suppose, my view is the picture is mixed. I think we've seen the successive governments have at least now acknowledged that we depend upon carers. I mean, the value is the equivalent of another NHS, estimated through Carers UK consistently over years. And you know very well, we all know actually, or many of us know, because we've been carers at different times in our lives, how important that is and how irreplaceable that is. you can have professional help and support, but nobody knows you like somebody that knows you well, I guess. So we have seen some engagement. We've seen the carers leave that was put into legislation, and we've worked within our own organisations across the NHS and social care to ensure that carers leave is enshrined, and we've worked with other employers within the city to ensure that there's some facility there where they want to engage with us. We've also seen changes in guidance to the NHS, particularly to acute hospitals, to oblige the hospital to engage with informal carers prior to discharge. That's had mixed success. It's relatively recent, and we continue to need to do education around that and help people understand how important informal carers are, not only to getting someone home, but to stopping them coming back again. So it's in everyone's interest to do that. So I think at a national level, that guidance, the carers leave stuff, some of the movement we've seen on the benefits issues that we saw this year, which were appalling, a few pence here and there putting people into real financial distress and worry, and I think we've seen commitment to try and resolve that through DWP. So we have seen some national engagement. We also have carers champions, usually in the House of Lords, our noble baronesses and barons and various other people. There's people there who've got real experience of caring. I think for us locally, I would say this carers strategy and action plan is probably the most shared, co-produced, depending how you want to look at it, but the most shared endeavour that we've seen in Portsmouth, because all of the organisations have come together and say it represents us. It's not just the Portsmouth City Council plan, if you like, and reviewing it via our local carers who have a say in that and can help us understand whether it's biting or not, whether it's making an impact or not, is really useful. But I say it's mixed because I don't think it'll ever be enough. That informal workforce is so fundamental to the quality of life and the outcomes for our residents who have care needs. We could never do enough, quite honestly. I think there's more work to be done in terms of the carers allowance, which is still, in my view, not sufficient to enable people both to work and care. I think we've done some good work locally around working and caring, but we've got more to do there. I think the engagement with the ICB, my engagement with our ICB colleagues is that carers is a priority for them. I think we saw some work recently around the dementia nurses in Portsmouth, and whilst it wasn't directly on a carers basis, if you like, it was raised by one of our carers in a carers group on in the north of the city. Our ICB colleagues came and engaged with that carer and that carers group, and that contributed to the work on the dementia strategy. So I do think there's good local engagement. I think there's always more to be done, to be honest.
Thank you for that, great and full answer. And then now there's not even a but. I just want to say I genuinely think we're doing the right thing with that model, because it's not a commissioning model that we need. We need a culture shift, and actually I think, and I know there's loads of people in this room who are carers, or have been, and it's actually sometimes just feeling that you're understood and valued that is a really key part of it, which obviously impacts your own mental health. So I'm not looking for a kind of one-track answer to it, but that was a really good answer, and thank you to everyone who's working on that.
Any more? No. I think it's like Susie says, it is a really fantastic, thorough report. So thank you for that, Andy. Go for it.
Could I just wish I could take the credit for it, but I can't. So if I and I should have said this at the beginning, so my apologies. There are numerous colleagues that have worked to bring this together and really worked to hopefully outline the impact of what we do. But we also have a fantastic head of quality and performance and a fantastic personal assistant who have made sure it's in the format and reads how it should. So thank you to them.
Get them some biscuits. Thank you. Look, they're already coming. James and Bernie, let's go. Take it that we've read and then just add any highlights. Thank you.
So, Bernie Allen, Partnership Director for Portsmouth, NHS Hampshire and Isle of Wight.
James Roach, Director of Primary Care and Local Care at NHS Hampshire and Isle of Wight. So the paper is a summary update as requested by the Chair following questions to the last meeting of Health Oversight and Scrutiny. We have added at the start of that paper some of the context. In particular, we thought you might want to see some of the extra work happening around winter preparedness and includes some of the successes that we've had with regards to the flu vaccination uptake and COVID vaccination uptakes across the city. But the main focus of the report is, as requested, the update on general practice access and activity. So I'll hand over to James.
Yeah, so building on from the last time I was here in September, I talked about the launch of online consultations, 10 hours a day, Monday to Friday. That's launched. The majority of our practices are compliant. We've got a handful of practices we're working with to support their transition. So big praise to practices who had to adapt really quickly to the change, adapt new clinical systems and new ways of working. It's making a real difference, I think, in terms of routine access to general practice. And also creating space by which we can manage the more complex on the day. If you look in the report as well, we highlight that we are seeing more extra same-day appointments. So over the last 12 weeks in Portsmouth, that's an additional 6,000 appointments, ideally focused on our most frail and our most complex cohorts. So that's dealing with issues on the day in the practice. You'll have a breakdown of numbers as they stood sort of the end of August. Just to let you know, across September and October, across Hampshire and the Isle of Wight, we saw a 7% increase that month of that year compared with the same month last year. Over 1 million appointments in September and 1.2 million appointments across Hampshire and the Isle of Wight in October. So demand is busy in primary care. The whole system is busy, and all healthcare professionals are doing all they can to manage that demand on the day and in surgery. Bernie's mentioned the vaccination programme. I think clearly that needs recognition. A lot of that was delivered in pharmacies as well. So we talked last time about the role of community pharmacy. They played a big part in terms of delivering vaccinations and sort of clinical services. And I think the other point then is pharmacy first again remains very high in terms of access. One of the questions last time was around types of clinical services. We also have a service in pharmacy now looking at the management of suspected urinary tract infections. And that's been really effective in terms of manage those with a diagnosed urinary tract infection and those showing symptoms as well. And across Hampshire and the Isle of Wight, year to date, we've seen over 4,000 referrals to pharmacy of that type. So again, reflects the range of work being undertaken in general practice. I think the other thing just to touch on in the report is the work across the rest of the system, particularly virtual care, virtual ward, hospital at home, and working in partnership with Hampshire and the Isle of Wight Trust on proactive care and management of frailty as well. So there's a lot happening across the system and there's a lot of connection across clinical teams. I'll stop there.
Thank you. That was a definite flyby. Any questions on the floor? All good. Oh, Judith?
I mean, this looks like good progress, but I've had two people reporting to me where an elderly person can't get an appointment. They've tried all the ways. They don't use they're told to go online. That one of them was Portsdown Practice, where a colleague, another counsellor, was really upset that somebody just couldn't get an appointment. And it was because it's all gone online, really. That's the perception that people got. And the person couldn't or didn't manage to get access by the phone. So it's not, we just have to monitor those things, because my colleague who's not got a health background, the other counsellor, was extremely upset about it and didn't himself quite know what to do about it in his casework. And so, there's a sort of sense that, counsellors who ask these sort of questions know about local government but don't know about health. Just another thing. My next door neighbour is wants a COVID injection, and he has applied for the power of attorney from me for health matters. It hasn't come through yet. I simply can't do it. I mean, I've been to the GP. It's the same GP as mine. I was offered a form which is designed for sharing medical information when you make a complaint. It's here. It's not designed for making an appointment for a COVID jab. he's a hermit, he doesn't ever comes out, he needs help at home. I fear we're moving into the season when he won't get one. I just am knocking my head against a brick wall every single time. And I've got a form signed by him now that I'm taking to the GP on the way home, which gives permission for me to look at well, it gives permission for me to, ironically, it gives me permission for me to look at his medical records to make a complaint. Neither of us are complaining types. We're not going to do that. So I've crossed all that bit out. And I said, all I want is to make an appointment for him to have a jab at home. It is near impossible to get through some of the NHS bureaucracy for that sort of simple act of trying to help somebody doing something very simple. I just report those things because actually the statistics look good. And I've noticed that and told people that from the previous meetings. I think I mentioned that last time here. But there are some individual experiences that still need some real looking at. And I think it is particularly people who don't use IT, can't wait for hours on the, or don't get response from IT. And there isn't a thing on my GP's, our GPs, we're on the same GP, there isn't a category to press the button and say I want to speak about this. You're expected to be able to at least turn up at a pharmacy. He doesn't get out of the house. There is a gap.
Thanks for that.
So I don't know how you're going to tackle that because...
Just be careful with private information, Judith. We're all being recorded, remember.
Yes, no, I'm the person who would be happy about it.
Any other questions from the floor? Oh, yeah, go for it.
Sorry, I'm new. Could you help me understand the table on page 81, primary care access table? There seems to be a lot of variation on the year-on-year difference, and I'm trying to get my head around what's better and what's worse, and maybe you could help me understand why there might be so much variation between practices.
Yeah, so the reason we present the table like this is the request of the committee so we can see year on year. We can't obviously include every indicator, so there's some adjustments for practice size, number of appointments per thousand. Some practices will be lower than last year because this just might be the basis of the demand, and some practices we've seen a significant increase on last year as well. The other thing is some of the data, particularly for October, still needs to be validated, so we just need to manage that through. What we're trying to give you is as up-to-date track on activity as we can, but some of that might be adjusted for coding. There may be some differences as well because some practices will do more vaccinations, they will do more same-day access appointments as well, so the nature of the access will be different. Broadly, those with a minus difference on last year is they're seeing less demand than last year, if you like, and those with a sort of not a minus or a 3.47% increase or whatever would be seeing more demand on practices as well. Broadly, practices are meeting that demand, but what we try and look at is where demand's coming from. Are practices able to meet that demand? What this data doesn't include is all the vaccination work that practices do, the additional same-day access appointments as well. So we'll try and make this a bit more comprehensive. But we're just trying to give you a track on demand into the service and where it stands.
That's great, thank you.
Mark?
Hi, thanks. Yeah, I welcome the report, and actually the additional information's useful as well to have, so thank you. Is there any, it might be too early I suppose, but is there any indication that the vaccination programmes are sort of on track to be at the levels that they need to so far? It's probably quite early for you to possibly know, but I don't know if you do know.
Sorry, just turn that off, apologies. That's not the answer, and that's the... yeah, I think so. I think obviously the more people at risk that we vaccinate and put care plans in place, the better that will be. What we are doing in each practice is risk stratifying patients who we believe are at more risk of admission or have underlying long-term conditions or are frail. So if we are vaccinating those that meet that criteria and we're doing it in a timely way, then evidence suggests that will have an impact as well. And that's probably something we need to look back on, and we try and monitor related symptoms through primary care and through the rest of the system. But broadly, it's not just about the numbers of people you vaccinate, it's vaccinating the right people early on to ensure that you prevent conditions. And just linking back to the comment that you made, there's very clear eligibility criteria for those. Often it's people who are socially isolated of a certain age with pre-existing healthcare conditions. So I'll take your point back in terms of how do we reach those people that can't advocate for themselves, but are on the practice list and could be identified that way.
And it is about the timeliness of it. Like, if I just think back to, you know, your school age vaccinations for flus, they actually came out before GPs in my residential area, which is a massive flip, because actually prior to that, it was the surgeries were done before the schools, and you know, whereas actually this particular school was done within the second week of starting term, and then the GP didn't actually come until third week of October. So it is about the timeliness of it. I mean, that's fantastic for schools because those little kids are petri dishes, so it was fantastic. But yeah, it is about the timeliness of it as well. The GP practices are getting those jabs in, so thank you.
And pharmacies as well.
Yes.
So I understand the about the criteria, because I mean I've had my vaccinations, but what I was just interested in is whether you've had any early indications yet whether the take up is the level it needs to be. And I totally get that it might be too early to know. I know, like you said, school children have had theirs, and there was thought that the flu vaccination flu is sort of early this year, I guess. So I don't know if you've had any figures for that.
So it is monitored nationally. So as we can see in the report, we monitor sort of where we are in terms of number of vaccinations and proportion of eligible cohort as well. So again, it goes back to that point in terms of what volume are you seeing of the eligible cohort, and are you vaccinating the right people? So the statistics would bear that out. It's not just a numbers game. It's numbers for the relevant type as well, which is important in terms of the prevention programme. Happy to share that context if that's helpful, Mark.
It's really good that it's the highest figure, so that's in the country, so that's sort of like positive. It was just really just seeing if there was an early indication if the
And just
level
Bernie's helpfully pulled up the graph. So generally, if you look at influenza, 65 plus, under 65 but at risk with one or more long-term condition, those that are pregnant and those of younger ages as well. And broadly, the uptake versus as a proportion of eligible population is strong. And we're monitored at 5 or 6 different levels, and within that pack there's 43 slides and various different graphs, so it does go into that detail.
I just wanted to just reinforce what Judith was saying about digital inclusion, because I was talking with Citizens Advice volunteers yesterday who are saying that the digital inclusion it affects all people of all ages, not just older people. And so I just wanted to reinforce that I think we need to constantly make attention to the people's access without using digital. Yeah.
And just to assure that whilst we've extended online access for routine, there is still provision of those that would prefer to phone or need to access through other routes. There's also a very clear point of clinical triage as well. So this is for routine, non-urgent. Urgent patients should be picked up at source, and we put more same-day appointment capacity into primary care so they can meet those needs more quickly. But I will raise the issues more broadly that have been highlighted as well.
Any more on the floor? Brilliant, thank you very much. Bernie, you can stay put. And we'll move on to agenda item 8, the Health and Care Portsmouth. Is Helen coming as well? There we are. Oh, yeah. Feel free. Use your mic, remember.
Just want to show the breadth of the partnership, because as you will all be aware, we'll introduce ourselves. I'm Helen Atkinson, Director of Public Health, and I chair Health and Care Portsmouth. Bernie has introduced himself, but is
Bernie Allen, Partnership Director for Portsmouth, NHS Hampshire and Isle of Wight OCB.
Andy Biddle, Director of Adult Social Care, Portsmouth City Council.
but also Andy chairs the
And Chair of P3.
which is
And the Prevent Board and various other things.
I've left. So, yes, as you see from the report, this is our normal 6-month update on some of the work we've been doing in Health and Care Portsmouth. It includes, obviously, a refresh this year of the 5 priority pillars, and most of those changes are just in line with either national policy, just to make sure that we are up to date. It also includes a P3 update, which, as you know, Andy chairs, but also it includes, because we're very proud of the fact that Portsmouth, Health and Care Portsmouth, and specifically the work in the P3 board, has led us to be successful in the Wave 1 National Health, I've gone blank, implementation programme, so, which is called the NIP, or the, yeah, so it's basically our neighbourhood health work. And there are, I think there's 43 across the whole country. In the main, 1 per area, but not just. In some areas there are more than 1, but we're very proud of that, so we wanted to include it in the report. And we are very happy to take any questions on any of the P3 update, the NIP, or the 5 priority pillars.
Perfect. Any questions? And again, another great report. So thank you for that, and well done.
Great work
as
to
well.
the team. Yeah.
Judith?
I've written down a question which has partly been answered previously, but I wanted to ask you particularly, the team of you. Under page 90, you talk about Portsmouth Provider Partnership, P3, continuing to lead transformational work across Portsmouth, and how you're dealing with that. I think a lot of us were frightened that with the ICB coming in and there'd be some levelling down, and you will have heard my question. Could that be said at all about the scope of the ambition of the Portsmouth Provider Partnership?
I don't think the ambition could ever be levelled down, to be honest. I think, I mean, P3 is, it's relatively unique, I think, in a lot of areas, because it is a gathering of most of the organisations that either provide or commission most of the care and support in Portsmouth, be that through acute hospitals or through community health, or indeed through social care and through the voluntary and community sector. So I think the ambition is still very strong, and the commitment of people who have a lot of other different demands on their time to come together on a monthly basis, understand the schemes in the city that we're running, agree money for new schemes, and try and improve the outcomes for our residents is still very strong. And I've been privileged to be able to chair it in a somewhat haphazard way for probably about 18 months or so, I think. So I don't think the ambition is scaled back. I think the money thing is always going to be a question. It's always going to be a conflict. We're very fortunate in that we've got what we would see as a legacy budget that we are still allocating from, and those schemes that we've listed in the report are funded through that legacy budget. That will eventually run out. It wasn't massive, but we've been quite judicious in the way that we spent it. And what we're hopeful of in terms of the money is that however we implement the NNHIP that Helen described, we move to some kind of localised commissioning, some kind of delegated budget locally. Our ICB colleagues are behind that in principle, because that's what NNHIP is. We'd need to do the mechanics of that. We need to understand which organisation holds the budget and all the stuff you'd want us to do in terms of good governance and good financial governance. But at the moment, we don't have any guarantee of that, because we don't know how the different configuration of all of our services over the next few years will work out. So I think the ambition is still strong. I think the mechanics and the money is something we really need to work on. But I think the model will probably sustain us through. If we think both about the changes in the NHS services through the ICB and in our providers, and the changes that we're going to see for local government through LGR, through local government reorganisation, I think the model is still sound. Bringing people together and supporting and investing in those relationships so that more and more of our residents have to see less and less people and don't go all over the place, I think is a really sound model, and I think that will be very popular in whatever configuration we move into. So it's a bit of a waffly answer. The ambition's good, the money we need to work on.
Completely with Andy. I think one of the things, because obviously you are aware that, so I'm going to say we are all very concerned when, because we obviously had very strong partnership working when the ICB came in with our existing relationship with the Portsmouth CCG. However, it's really important, I think, to note the Health and Care Portsmouth Partnership, and therefore P3, is a partnership of for all of us. The ICB are members, the Acute Trust, the Community Trust, the Primary Care Alliance, PCNs, the Hive, ourselves in the council, and I've missed somebody else. And the university more recently have joined us. And what's important, it very much is a partnership approach. And we all bring, because I do know we were all very disappointed, no one more so than Bernie, when we were told that there would be no additional national funding with the national neighbourhood health programmes. However, and this is going to sound of a glib answer, but we've all got funding within how we're working together. So this is about us being innovative. This is how I see it. Maybe there will be funding further along the line, but it's about how we innovatively work together to get the best out of the existing funding that we all have across our system, which is tight, but it's doing things differently. And I think that is the art of the possible, both in the P3 and in this programme. And for me, having had that concern, and we've had, it's been some quite challenging times across all of those partners in terms of funding. But this programme has re-energised, bringing us together and facilitating us to continue with that vision that we've always had around how we together meet the needs as best we can of our residents in Portsmouth. So it's re-energised it, I think.
I think that is a beautiful answer, really. I think there needs to be more people that take that approach, really, of working collaboratively. There's no hierarchy, actually. It's for the users, it's for our residents, it's for the patients, you know. So, you've been doing some fantastic work, and obviously will continue.
That's really, really helpful. We faced this challenge when I was running the health authority across Portsmouth and South East Hampshire, and we found it necessary to keep a focus on actual need. And Portsmouth is still a poor city, and it's a city in poor health, and therefore we needed to look at equality of outcomes, not equality of inputs. And I was particularly worried that the ICB would be too far away to be able to keep a focus on equality of outcomes rather than equality of inputs. And I'm very reassured with you. I'm really reassured by your answer, and that was reassuring, because I was saving up to ask that question for about now in the cycle, because at the beginning when the ICBs came in, I was extremely worried about those things. So you're doing some great stuff. That's really great.
Can I just ask you about the cervical screening survey that got sent out? So that seems like quite a good response, 6,000. So I just wondered what some of the feedback was from them, because it says here that you're using the findings to shape the target and interventions, but I just wondered what some of the highlights were really on their feedback.
We're still, because the survey's only recently closed, we've got the report, and Hannah Byrne, many of you will know, is our lead for sexual health, and we are working through it now. So what she's using their feedback for, we've notoriously, cervical screening has always had quite poor uptake. It's, many of us will know, it's not the most pleasant experience. So what we're doing, and I suppose it goes back to your earlier question, and this is really important in the work that we're doing across Portsmouth, in all of Health and Care Portsmouth, is we are going to our residents to get feedback, to learn from why they find it either easy or not so easy. And she's using that as part of the commissioning and intentions. We've obviously got a contract with our local primary care, with our local GP, so it will be used to try to get better. better outcomes, because obviously the whole point of screening is to identify and get better outcomes and if treatment's needed. But importantly, that work is part of the, because you'll be aware, there's a new, I mean, actually today's very timely because the National Men's Strategy is out today, but this part of this work is all part of the women's health strategy and trying to ensure, it's something I think, Councillor Fulton, we talk to you quite often about this, it's trying to ensure that there is equity but also a good experience for our women, because it is fair to say that women have felt, and of course today is the point that men have felt, that they've not necessarily had access to the right services, and I think both together is a fantastic way forward, but it's really trying to ensure, particularly around some of the female health issues around, well, through puberty, menstruation, and also I talk my own experience, menopause and postmenopause. So it's trying, all of that is trying to get a better understanding of how women experience the services to try to make changes. And it's slow progress, but there is some early progress. And I hope to see the same. I just wanted to raise it. I'm not looking at you in any particular reason, Andy, but apart from that you are a man. And I think it's really important around men's health as well. And I know I just was listening on my way in today to the Health Secretary talking about the need for better access to mental health, particularly because it is the highest cause of death for men under 50, but also we are starting, now I'm going over and beyond, and hopefully next time we get a public health update, you'll hear around some of the work we're doing around gambling, because that's also another major health issue. And so lots going on. But did I answer your question? I can't because I haven't got it in front of me. Oh, too soon for that. But for the cervical screening, it was purely to get the data. Yeah, sorry.
I just wanted to add, I think, and yeah, it is too soon, so we can certainly bring back more information. I think one of the things that stuck in my mind when we reviewed this at P3 was that the contact that we'd made with women through the practices had been expanded through word of mouth. So even if people hadn't had, it was a text in the main, they had talked to their friends. And so we got more bang for our buck, if you like, in terms of those messaging. And we know that word of mouth is more trusted, more reliable, has a far stronger effect necessarily than standard communications that we do. So
because it used to just be a letter.
Exactly. Yeah. I think that reinforces it. I think it also links to some of the work we're doing in the city. Something I never fail to mention, because I think we're really proud of it, is Project W, where we know that working with our women who use substances, them having an all-female environment is really, really important for many, many reasons, not least previous trauma. And so I think these kind of initiatives not only happening, being publicised, being commented upon is fundamentally important, really important. And just as a plug, let's not forget White Ribbon Day next Tuesday, please. Anyone who can get there to raise the flag, make any contribution, make the promise, please do.
Thank you. Thank you for that. Any other questions? Perfect. Thank you. Agenda item 9, Juliet Pearce. Welcome. Take it that we've read the report and just add any highlights. Thank you.
Thank you very much. I think I've met some of you before. I'm Juliet Pearce, Director of Nursing from PHU, not Simon Barson, you'll notice, who's our Chief Operating Officer. He's in London today, so I hope I'll be able to do justice to any questions you have. I think we were asked to bring an update on where we are with our urgent emergency care performance. So you'll see the summary tables there around performance against our 4-hour standard, ambulance handover times, our 12-hour standard, and there is some information in there around the things that we are doing to be able to meet some of that increasing demand. There's also some information there about not meeting criteria to reside in the work that we're doing. You'll have heard some of it today from our partners who are talking about how we manage patients who need to be better cared for in their own homes or in community provision in order to reduce the demand in the hospital and increase access to emergency care. And then there's a little bit of a summary around our winter plan and the commitments we've made and the work that we're doing to achieve that. So I'm happy to take any questions.
Perfect. Over to you guys. Any questions? No? Wow. Now that's the sign of a good report, isn't it? You've come all this way. Oh, go on, Susie.
Well, it's not so much a direct question, but actually I think it's partly as a way of saying thank you for this feedback. I guess it's the age-old thing around waiting times that we hear all the time, and I just think I don't think there's a week that goes by where I don't get anecdotal stories about waiting times at QA. And in actual fact, some of those people are not moaning. They're actually saying, I didn't know where else to go. I couldn't get a GP's appointment. I was then sent to the walk-in centre. The walk-in centre, don't stay here, go up to A&E. And of course, in that moment, I guess, when you don't know what's wrong and you don't know how serious it is, then you do go up there. And I can think of, I'm actually not exaggerating, 3 separate occasions in the last few weeks where those people have then gone home because things have moved on, I suppose, in their thinking, maybe their crisis thinking, or and they've actually walked out of A&E, which probably says that they didn't need to be there at the beginning. What can we do around trying to prevent people? I mean, I know I've got to that point where I'm old enough now to say, when I was younger, you only went to A&E if you fell out of a tree and obviously broke a bone, or there was some absolute crisis that people stayed at home with temperatures, feeling really rough, etc., etc. I don't think you've got the answers, but I wanted to raise it because that is the thing that comes up time and time again. And even with the new model at QA, it seems to be that I'm hearing as many, if not more, stories, despite that what seemed to be a solution to a problem.
Thank you. And it is a wicked and complicated problem. I think you can see in the data that all urgent emergency care demand is going up, but type 1 demand, which is the most critically ill and unwell patients, and they are patients that require emergency department care, is continuing to increase. So I think it's really positive that the work that we're doing around our GP at the front door service and our emergency care centre, which we call UPEC, we've now co-located those, which makes it easier for our ED nurses to stream away. And we've put in some sort of rapid streaming. So rather than patients coming into the department, having a set of observations, having a triage and being redirected away, we, in line with other really good providers who've modelled this, can do a rapid streaming at the front door that has a quick conversation with the patient, does an oxygen saturation, pain score, and if they don't need to be in the emergency department, they will be redirected to our UPEC, I'm going to call it, it's hard to say it in one word. And that is certainly helping in that demand and decreasing waiting for those patients. So we've seen about a 2 to 3% increase in performance against the 4-hour standard for that group of patients. I think there are still some really significant challenges with access to care for those patients who need majors care, resus level care. And that is part of the work that we need to do around the not meeting criteria to reside, because as of today, we have about 269 patients in the hospital who don't meet the criteria to reside. And if we can't move patients through the hospital out into beds in the hospital, you get patients who need to be admitted who are waiting a longer period of time. So we are doing a huge amount of work with our community partners. We've got a 6-week discharge sprint, which we're in the first week of this week. And some of the work that you've heard around increasing community care at home for patients who require reablement, packages of care, those things will help us because that probably is the key to the 12-hour wait performance, and for those patients that really do need admitting to a hospital bed.
So sorry, you've got 269 patients that are not required to reside.
Yes.
So why are they still there?
Because they can't access community care, and there will be different stages in that. So some of them will be waiting for an assessment, some of them will be waiting for capacity, and that would cover everybody from a patient who requires a once-a-day package of care to a patient who needs a nursing home or a residential home placement.
And this is before the Christmas rush. Oh, wow. Okay, thanks.
I suppose as a comment, Chair, in relation to your 269, I guess that links back to the first item that we talked about, which is beds in the community. So it is related, but that I was staggered at that number as well.
I think back to, so I've got a young child, and pretty much every winter period throughout her life, she's ended up in hospital with croup. She's severe asthmatic, and actually last night was probably my first time that I thought, oh gosh, here we go again. But something that our GP service has done is that prevention of, because we've been through it for the last 5 years, actually I have a stash of steroids. I phone 111 and I can manage that at home. So actually quite a lot of this, well, I know actually not quite a lot of it, but some of it could be prevented to actually going in anyway. Obviously broken bones, heart attacks, strokes, they take priority obviously, but some of the stuff I suspect could be, if you can have that relationship with the primary care, then actually it could be prevented possibly.
I agree, and I think that focus on admission avoidance schemes is really important, but also the vaccination that we're talking about. So we know that the flu season is rapidly approaching. It has hit paediatrics earlier than it has hit adults. So in a way, it was interesting to hear you say that the schools got vaccinated earlier. Might have worked out quite favourably. I don't know if that was planned because the flu wave in children hit earlier, but that is really important for the hospital that vaccination programme is happening, because patients with comorbidities will be much less likely to require inpatient care. And as part of our winter plan, we are also focusing on where we do have patients that are in our hospital bed, not meeting criteria to reside, but waiting to go to a rest home or a care home. If we can vaccinate them while they're inpatients, we will, so that they don't miss out on that opportunity. And that will be really important to them, and also the wellbeing of the people that in the home that they're going back to. And in terms of staff vaccination, we've had a really, really good start to the vaccination season, because obviously keeping our staff fit and well and in work is important. And we're at about 47% of our frontline workers vaccinated, which is much, much higher than this time last year. So we've seen a really good response to the request for staff to get themselves vaccinated.
Is it not compulsory?
It's not compulsory.
Oh, interesting. When I used to work in the NHS in a very lovely hospital down the road for oncology, they used to just come around with a trolley, and 9 times out of 10 it was just stuck in your arm, and then you signed a bit of paper, signed a bit of paper afterwards. But no, it's nice.
You do have to consent, but we do still send people out with trolleys to vaccinate, because actually in terms of the trusted colleague, we have a really good offer in our main atrium that does vaccinate a lot of people, but actually sometimes a trusted colleague sort of saying come on and talking you through the reasons why it would be good, and some of that myth busting around the vaccines is proving to have a higher uptake rate.
That's good.
47% doesn't sound very much.
So the total last year at the end of the vaccination season, so we've got weeks to go yet, was I think it was 53%, and this time last year we were probably at about 41%. So we've been consistently ahead of that. Our target this year is 57.8%, so that would be a 5% increase. I would love to get to 75%. I'm working on it daily.
Brilliant. I just want to credit the kind of acute oncology service. That system, I don't know what it is. If you've got cancer, you seem to just bypass QA. The A&E kind of thing, and get through there. But that service at seeing patients like within an hour, you know, from home to being seen is absolutely spectacular. So credit to the staff up there. That's
Thank you, and I'll pass that on. And I think that is another really important point actually, is that access to other areas like that for different conditions. So cardiology SDEC, respiratory SDEC, if you or your GP knows the specialty care you want, you would better divert it around the emergency department into that place where you could see rapidly by the right specialty. So we are doing lots of improvement work in our medical SDECs, but I'm pass that back to acute oncology because it is a fantastic service.
Anything else? No? Brilliant. Thank you very much. Flying through. Right. Item 10. Siobhan. welcome. I think last time we had a bit of confusion, didn't we, about, yes, so it was nice of you to join us. So take it that we've read the report and then just highlight any key points. Thank you.
So, Siobhan McCarrick, Healthwatch Area Director for Hampshire and Portsmouth Healthwatch areas. I was asked to return to provide some more longer-looking outcomes derived from the activities that we reported in on the annual report. So this annual report was for 24-25 that was published in June, 30th of June, and we presented this and the highlights from our annual review to the September meeting that I wasn't able to attend, so unable to answer in person. With regard to actual outcomes that Councillor Judith Smythe was wanting to have determined, the template that we use for the annual report is set by Healthwatch England, and in the table that I've provided for today's meeting, I've created it as a 3-column table. This is towards the end of your set of report papers that would have been circulated, because I was trying to show the longer term outcome, if you like, rather than the achievement that I had previously identified as an outcome. The reason I was hesitant to make this extra category is because it's difficult for Healthwatch to claim the overall outcome, because we do not track the patients like the NHS does, because we do not have the patient registration number, we don't have an identification label that we can use to identify, well, if somebody got help there, then they've ended up 6 months later not needing a service, for example. We also don't do individual casework, that's for advocacy services, but what Healthwatch across the country track is trends and outcomes on a patient community rather than individual cases, individual patients. We may get told about issues by individuals, but then we look at the impact on a cohort, shall we say. So if I can just go through from the top of the table, just to give some examples of what I'm bashfully hoping is not an overclaim of what Healthwatch Portsmouth has achieved as an outcome. However, the Health Inequalities Research Project, which achieved the fact that the Integrated Care Partnership for Hampshire and Isle of Wight used our findings for informing its system prioritisation work. So that was great. Over time, health inequalities faced by Portsmouth residents should be reduced based on the fact that the Integrated Care Partnership is going to be using that intelligence. I can't tell for sure whether that's definitely going to happen, but I am making the educated assumption that there will be some reduction over time of health inequalities from our findings. Similarly, the second one down, which is improving residents' access to and understanding of information provided on available services in the city, is a very tangible output as well as an outcome, because through the P3 board that Andy Biddle was talking about before, funding has been approved and is available to pay for 2 staff to provide in-person support in Paulsgrove and Portsea, which is starting next month. I'm so pleased that the Healthwatch Portsmouth Inequalities Research Project findings created this momentum for the work done by the engagement teams with the council and Health and Care Portsmouth to provide this service to help residents unsure of what to do, where and how to get services. So I'm truly happy that the help desk community help desk, which is starting in December, is a result of Healthwatch research. So I am happy to trumpet that one because that's something I personally was very deeply involved with. So in terms of the Accessible Information Standard, we are informing the Integrated Care Board to understand what's going on, and therefore patients will be able to access information in a way that works for them longer term. Similarly, Blue Badge holders are now more able to understand the information provided at St Mary's Hospital to do with the car parking, because we worked to actually make sure that that information was clearer for the user in the car park, saying, what on earth do I do with my Blue Badge? So the right-hand column, the outcomes, are what I have anticipated are benefits from the work of Healthwatch, working with partners and supporting that intelligence gathering for decision making. At the end of the day, that's what Healthwatch does as a service. And if you're wanting to know what the future of Healthwatch is, because that was an announcement made in July by the government, we're not that much further forward, but we do know that in January there's to be an update for Healthwatch. We were told at the beginning of this month, late last month, that they were definitely working on plans for the legislation to be laid before Parliament between January to March. And in January, when we receive an update, we will have a clearer understanding of what that means for each local Healthwatch, the 151 of them. If there's a 12-month run through Parliament of the legislation that the government wish to bring through, you're looking at perhaps March 27 being the end point of Healthwatch. But until we have been given information about that, and until we know when Healthwatch will not be commissioned, we are working as business as usual, doing great work, looking at how we can inform decision making, not only in Portsmouth, but my role is also doing exactly that for Hampshire. And we are hoping to do what we can, work with patients, work with service users and residents to inform local decision making. So, all right.
Excellent. That's what we like to hear. Any questions? No. Thank you.
Great.
It is perfect. That's
okay.
Exactly what we needed.
And I just wanted to say, if I may, that with regard to primary care, you were interested in James Roach talking about how patients were finding the new access to primary care. Well, Healthwatch across the 4 areas in Hampshire and Isle of Wight are preparing a survey to ask patients what's changed. So that is coming, and we will be working across the 4, combining the report, and that will be published. But we are going to be asking people, how is it now? Because we've been hearing for years and years and years that, as you're saying, the access has been horrific to make an appointment. And with the advent of digitalisation of the NHS, for some people that's just worse than going to be better. So we are asking that, do people know they can go in by person? Do they know they can phone? Do they know that now the online is open for much, much longer hours than it used to be? But equally, if they want to cancel an appointment, how difficult is it? Using an online platform, most people find it so difficult they just don't bother. So the DNAs that James Roach no doubt has provided you with statistics about, it's quite high. So if they work on how to improve the way people can cancel appointments, or ask people why was it that you couldn't make it, that also helps. And finally, I just wanted to say that with regard to emergency and urgent care, that looking at actions to help with reducing wait times and perhaps avoidance of admissions, we've very recently been working with the Trust to identify what Healthwatch Portsmouth's recommendations were made when we did a walkthrough of the emergency department. And we've actually identified where the Trust has made changes, they were because of Healthwatch. And we are going to be publishing a report to say, because we said that, this has changed. And that sort of stuff is really important for patients to know, because then it encourages them to have their say.
Thank you very much.
Thank you. Sorry to
Oh,
hog.
Susie's got a...
Sorry, only as a result of what you were saying. Sorry for everyone rushing to... I'm just really interested in the survey that you're going to be doing
for
around the
primary
primary care.
Okay,
Because
yep.
you are obviously a trusted voice. I think the response you might get might be different from other people.
This is the whole point
Yeah.
of Healthwatch and why
So-
we want the independent voice to continue.
Really, really, really interested in that. Have you got any kind of timeline about how long it will take, and also it's just so that whether we could receive maybe a report back or something? I know it might be a year or so, but it depends how long it takes.
Yes,
but
certainly.
so that it doesn't slip under our
We are hoping to have the questions done by the end of this year. We're hoping to get it out in January because people's current experience is what we're trying to capture, rather than saying, can you remember 6 months ago, what was it like? So we're going to try and capture the moment, if you like, and if we can report back by the middle of the year, fantastic. But, you know, we want, it's you know, short, sharp stuff rather than 6 million years to
That would be
gather the
fantastic.
information.
You know, yeah, definitely, especially as decisions will be made in January, March. You don't want that kind of
Yes.
running on. But yeah, no,
Yeah.
that's brilliant. That would be great. Yeah.
So we will obviously certainly share the results, but we'll also share the link so
Yeah,
that it can be pushed out as far and wide
can
as
complete
possible. And indeed,
Yes.
indeed. So that's, yeah, fine. Happy to do that.
Amazing. Thank you.
you.
Oh, Judith.
It's a little question. We, in fact, passed, I can't remember if it was unanimous or not, we passed a motion through full council, didn't we? Supporting the continuation of Healthwatch.
Thank you very much. I was invited to do a deputation, but I didn't hear anything further, so I didn't know where, how to go.
You can look online and find out the
Super.
debate.
Well,
and we
thank
did,
you.
But I do urge other people from other authorities to do the same, because the current legislation doesn't give any provision for the sort of independent scrutiny of the health service, which I think has always been really useful. Hasn't always been Healthwatch. Before that, it was
there was links, and
powers,
then there was
patient
yes,
liaison.
and patient
but I mean,
forums.
having been involved in healthcare governance for a long time, I always found the insights from the equivalent of Healthwatch really, really useful. So other authorities, you might want to get that on as a motion in your authorities. So we've got a full, full South East Hampshire support for the continuation of your work.
Thank you, because we're trying to work with councillors and MPs once it goes into that discussionary period to question what is being proposed and what is the independence to be maintained once the Healthwatch is, no longer commissioned. There should be a service available for people to actually feel there's a trusted patient champion there. Thank you. Sorry to hog, but
Totally agree. Thank you. Anything else? No, then we're closed at 14:59 with the bongs of the bell. Our next meeting is on Wednesday, 21st of January. And Lisa will be in touch with stuff. But thanks.
Thank you.